start yet another grand rounds, Vertigo grand rounds. Today we have a very, very eminent panel of specialists with me, and a totally different topic compared to what we generally discuss in Vertigo circles, but yet it is not a uncommon thing is what I have been seeing in practice. So I'll go ahead, and as the way this grand rounds is conducted is something like this. We make a case presentation, one of us.
Hello.
One of us may, I think Vishnu or Abhishek, you'll be taking care of guest joining, right? So I don't have to take care of that.
No, we will take it.
Yeah, okay, fine. So the format is something like this. What we do is we will present a case, okay, a representative case, and then we are going to, then I'm going to present some of the theoretical background required for a discussion of that particular case, following which we'll bring in panelists who will be answering the questions that are raised to give more clarity on the particular topic and to add more information, more knowledge onto that topic. So as is the usual pattern, I'll go ahead and now present the patient and then do some of the background discussion also before I call the panelists in. No, I'm sorry. I think in excitement I forgot to introduce the panelists. I'll first be introducing the panelists. So if my co-panelist today, my panelist today is going to be Aditi. Okay, as you can see here, Dr. Aditi is a sports physiotherapist with she's young but with an illustrious career already. In the sense, she's already worked with the who's who of in the athletics field. So the athletes that she has worked with is Rohan Bopanna, Nikki Punacha, Sharmada Balu, Shravya, okay, Samiksha Dabbas, okay, from ITA and ITF champions. Then she has a D license, Hero Indian Women's League 2019-2020 held at Bangalore. Okay, she's a consultant physiotherapist at multiple hospitals, clinics, orthopedic clinics, and also sports schools. Okay, she has been a sports physiotherapist at Bridge Plus Physiotherapy and Sports Rehabilitation Center, sports physiotherapist, okay, at the Center for Sports Science at Kantirava Stadium. And then she's been a sports physiotherapist for the World University Games, tennis selection, men's and women's, CCE Cup and Red Bull Cricket Championship. She has a huge number of experience, including for Oxfam Trail Walker. She's been a physiotherapist volunteer from 2014 to 2019. She's been the on-field sport. She has done on-field sports instructive training at the Spark Institute, Chennai, and also for the regional Ranji selection cricket under-17 sports injury assessment for cricket players at KSCA Chinnaswamy Stadium. And of course, she has attended multiple conferences and then continuing education in some multiple workshops, certifications, and apprenticeship. I welcome Dr. Aditi to this panel. Ma'am, welcome.
Thank you, sir.
And now I I'll be my other co-panelist is Dr. Venkatdeep. Okay, so Dr. Venkatdeep. Say again, Dr. Venkatdeep, I've been knowing for a long time since our days together at MS Ramaya Medical College. Okay, he's done a fellowship in orthoplasty, fellowship in computer navigation, and revision replacement. Okay, he has multiple fellowships to his credit, and he's an MBBS from MS Ramaya, the same place where I worked with. And he's been a consultant orthopedic and joint replacement surgeon. As I mentioned before, he's done fellowship in navigation and revision. Okay, and he's a huge experience. And most important thing is he's one orthopedician whom I trust for a lot of my relatives, my friends. So he's the go-to orthopedician with the deep insights and a tender kind approach towards the patient, and a very competent orthopedic surgeon. He has multiple research, huge research experience also, and his publications, okay, are adaptation of obesity disability index to Kannada language and evaluation of its validity and reliability, functional evaluation of hemiarthroplasty, neglected fracture neck femur, and surgical treatment of malunited collis fracture. In addition, he has had multiple presentations and has won gold medals at very big conferences of repute. But he is a great organizer too. So with that, I welcome Dr. Venkatdeep also to this panel. So Dr. Aditi and Dr. Venkatdeep, welcome again.
Thank you, sir. Thank you for having me.
Now coming to today's case discussion. This is the 10th grand rounds, I believe. So thank you all for taking time out every month after month and joining us together during this grand rounds. Okay, this is not one patient. There are multiple such patients we have come across so many years, which I want to just take as a one representative patient to show this, to tell how these are. Most of the main complaint of this patient is difficulty in walking. However, over years of repeated consultation, they may first start off saying that I've been diagnosed with vertigo, doctor, but nothing is giving me relief. It is something like this. It is only after some amount of questioning, and then after listening to them and all that, and then asking like, what exactly is your main problem? Tell me that. Then they will start telling, my main problem is that I have difficulty in walking. They will even say my biggest fear is of falling, and the other fear that they express is, this is I am afraid that I may eventually become immobile. Okay, so this is the kind of thing that these particular patients express. But most of the time they come and tell vertigo or dizziness, whereas it is not vertigo. Okay, and most of them are above 60 years, some, and then some are even above 70 years. Multiple evaluations have been done for these patients, including non-contributory imaging studies. Okay, a few MRI scans are already done. They may show age-related some changes, but they are not sufficient enough to explain all the patient's problems. Okay, and with detailed evaluation, frontal gait disorders, basal ganglia disorders, cerebellar disorders, peripheral neuropathy, all have been ruled out, but and even bilateral vestibulopathy would be ruled out, but this patient still has a difficulty in walking. Okay, one example of the video of one such patient is here. So when you make, this is the kind of walk pattern that you see. So this is the kind of walk. So this kind of a patient reminds me actually of seeing those in the pediatric wards during our internship days of kids with muscle dystrophies. Those are the kids who would walk like this, and even adults with muscle dystrophy. These are the people who would actually walk like this, and these patients typically reminded me of that particular case. That the problem possibly is related to the muscle, and it is not related to anything else, and most of the other evaluations have turned out to be normal. So the European consensus group, okay, on sarcopenia, this is a very, very recent diagnostic entity. In fact, it has been added to the ICD after a lot of lobbying as one of the diagnostic entity there in ICD-10, okay, International Classification of Diseases. So Sarcopenia, revised European consensus on definition and diagnosis, defines this on 3 criteria: low muscle strength. This is the 2018 operational definition of sarcopenia. Low muscle quantity or quality. when it was first discussed, the sarcopenia, it was only about loss of muscle or something like that. But now the more importance has been given to loss of muscle strength. Okay, and then loss of low muscle quality or quantity and low physical performance. Okay, so probable sarcopenia is identified by criteria 1, where muscle strength is low. Diagnosis is confirmed by actually demonstrating that the muscle quantity is less or the quality of the muscle is less. And then, if at all you find criteria 3, it is meant that the sarcopenia is actually very severe. So this is the operational definition of sarcopenia. Operational definition of sarcopenia. Now, what exactly, why should we be worried about this particular thing? First and foremost, we should be bothered about knowing this condition called sarcopenia for the reason that this is unrecognized, okay, to a great extent. And this is a very new entity that is being recognized. And a lot of patients continue to be troubled by difficulty in walking, okay. But with multiple evaluations have shown nothing. I have seen some patients in whom there are 2-3 big folders of files, huge ones with so many investigations done, but still not having received a label or not having been told that their main problem is muscle weakness. Okay, why should we what all it causes? It causes increased risk of falls and fractures, impairs ability to perform activities of daily living, is associated with cardiac disease, respiratory disease, and cognitive impairment. Not cognitive impairment leading to gait difficulty. This itself leading to cognitive impairment. There are publications to show that. Leads to mobility disorders and contributes to lowered quality of life and loss of independence and need for long-term care placement. Everything one after the other they can. In fact, this is what the patients fear, that I may end up being long-term care. I'm being placed in a long-term care or I lose independence. This is the fear that they express also when they first start noticing a difficulty in walking. The types of sarcopenia, there can be just primary, which is simple age-related loss of muscle strength, or secondary. In addition to age, there are other factors. Okay, in addition to age, there are other factors like systemic disease, malignancy or organ failure, physical inactivity, inadequate protein energy intake, like this. And then there is another condition that needs to be recognized, that is sarcopenic obesity. See, loss of muscle tone, loss of muscle strength and loss of muscle bulk is not always detectable just by checking the weight of the person. Okay, because what happens as people age is that they lose muscle bulk, but then aging also is a risk factor for adding fat. So what happens is eventually the body mass itself may be same, but it is the lean body mass which reduces. Sarcopenic obesity is a condition of reduced lean body mass in the context of excess adiposity. Okay, so obesity exacerbates the sarcopenia, increases the infiltration of fat into muscle, lowers physical function, and increases risk of mortality. Now, for the European consensus group, the need to make this very important and to make sure that everybody really starts recognizing this as a condition. Okay, they have come up with some guidelines. Okay, one is, the first of them is to find cases, to identify individuals at risk of sarcopenia. Okay, advises the use of a questionnaire called Sarcaf Questionnaire. Okay, or just on the clinical suspicion that the person may be actually having a loss of muscle strength. Okay, which is age related or age plus other things when it becomes secondary. Then once you suspect, okay, or identify at-risk people, then you assess them to assess for evidence of sarcopenia. Okay, for that you do grip strength or a chair stand measure with specific cutoff points at each test, which I will be showing some of them in the further slides. Okay, if it is in a special case, there are other research level, then there are other methods also. Then you can do X-ray absorptiometry or a CT or a MRI to actually measure the amount of muscle at a particular location in the thigh to find out. Then how bad or how severe this person is having. For that, you do functional assessment like gait speed, this kind of thing, or a 4-meter walk test like this. So first is find cases, use simple screening tools, then assess by using chair stand test and muscle strength, then confirm that it is there by X-ray absorptiometry or a CT or a MRI, and then label or I determine how severe is it when it is, though it is confirmed how severe it is by physical performance task, and then do the interventions. Okay. So I'll just show you one of the tests that is done to do the 1 minute. I'll just So Sarcaf questionnaire is this one. So this is Sarcaf stands for strength, assistance in walking, rising from a chair, climbing stairs, and falls. So the scoring is question that is going to be asked for each of these things is for strength. How much difficulty do you have in lifting and carrying 10 pounds of weight? How much difficulty you have walking across a room? How much difficulty you have transferring from a chair or a bed? How much difficulty do you have climbing a flight of 10 stairs? And how many times have you fallen? The last, So for some reason, the questionnaire that I found, the last thing is not entered correctly. It should have been a different way. But what the way it is scored is for strength. Okay, how much difficulty? No difficulty, some difficulty, a lot, or unable. So the scoring is 0, 1, and 2. So something like that. So a score equal to or greater than 4 is predictive of sarcopenia and poor outcomes. If you get 4, like if the person tells like, I have a lot of difficulty or in carrying 10 pounds weight, or I can't walk across a room, I have a lot of difficulty, then use too many aids to be able to walk around. That itself makes it a score of 4. So like that. Or if I had falls, multiple falls in the last past year, 2 falls, more than 2 falls in the past year, then that also makes it very high. Okay, so like this. And then to make specific tests, there is once you have to see how severe it is or whatever to assess, you can use a dynamometer. This is something called as a hand grip dynamometer. So you give this particular thing to the subject and ask them to check the strength of their hand grip. And then the other thing that we can do is actually do another test, which I will be showing. I'm just taking the link of the, I hope you are able to see the YouTube video. Okay, that is 5 times sit to stand test. I don't know, for some reason this is not playing. So that was the 5 times sit to stand test. And I'll show you the scoring pattern. So the scoring pattern is something like this. For the grip strength, for cutoff points for men is 27 kgs. So it should be above 27 kgs. For women, it is less than 16 kgs. Okay, chair stand. Okay, they should not take more than 15 seconds for 5 risers. So they should be able to finish 5 risers in less than 15 seconds. Okay. Then for the actual then there are other cutoff points for gait speed, okay, and the 400-meter walk test. So non-completion of a 400-meter walk or taking more than 6 minutes for the completion of a 400-meter walk, timed up and go test of greater than 20 seconds. So, or a gait speed of less than 8 meters per second. These are all things that will suggest that there has been a low performance, which tells that the sarcopenia is severe enough. Okay. Then coming to the grip strength. Okay, so the grip strength itself with age. Okay, so grip strength with age around 20 years is when 25 years when it peaks, and then as age passes, okay, grip strength starts going down. Okay, and for women also the pattern is similar, though the peak grip strength that they achieve is a little less. Okay, and then when it comes to overall muscle strength and life course, see the muscle strength peaks again in youth, and then if with a lot of physical activity maintained, then it instead of plateauing, it starts falling. It falls, but then depending on how active the person is, the fall may be less or more. And that amount of fall, see, in some individuals, the extent that it falls in old age is very less. In other people, other individuals, the extent of fall in the muscle strength as they age becomes even more severe. So the approach to this patient that the consensus committee recommends is that maximize muscle mass in the youth. So the more the person builds up muscle mass in youth, the more that the person is here, there is more quota there to lose, and therefore he will, if he starts losing a little bit also, he will still retain some amount in the old age. So maximize muscle mass in the youth, maintain in middle age with exercises, and minimize muscle loss in old age. Okay, so some of the physical cutoff measures are given in this slide. Okay, if it comes during the discussion, if this comes, I'll just again come back to this particular slide. Okay, slide. Okay, so with that case reported and with this background, I would now request our panelists to come in. Okay, and give their initial thoughts. Okay, first, may I request Dr. Venkatdeep to give his initial thoughts?
Good evening, everybody.
Yeah.
At the outset, first, Srinivas sir, thank you for having me today as a panelist. So sarcopenia, actually, it's something that is gaining awareness now. It's probably under-recognized and under-reported at the present moment. And as you rightly mentioned, only recently, it has been included in the ICD-10 as a separate diagnosis. Before we would just say, old age. But right now, this is the time that we actually need to recognize this as a separate, clinically detectable entity. And of course, as in practice, I do deal with a lot of elderly patients, and it becomes very relevant to actually have a fair understanding of this, because it largely impacts, it causes a lot of impact, especially if there are falls, if there are fractures, the recovery post, all these things are very, very critical. And sarcopenia has a major role to play in these things.
Yes, sir. So thanks for those initial thoughts. I'll come back to each of the points that you raised, okay, because I have all those things in mind to ask more specifically. Dr. Aditi, your initial thoughts.
Yeah. First of all, I thank you, sir, for giving me this opportunity. Am I audible?
Yeah, you are very much audible, please.
Okay, right. So as Dr. Venkat said, sarcopenia is something which is very new for the general population. Though it's been a concern since a while, think in 2018, the WHO with the population, with the geriatric population, which they expect to have to be 1.2 billion in the 2025, the sarcopenia has been a very, it's a condition which is need to be, we need to consider that, which needs to be treated or which needs to be evaluated properly. So yes, as you said, it's something which anyone can have it. It's not something, it's like a condition or something, but it's something every population will, every age generation will definitely face it. So
yes, ma'am.
once
So yeah. Dr. Venkat, see, generally what happens is frailty is considered something natural for the certain age, after a certain age. We think the elderly people are more frail. But the European Consensus Committee says that this is not the same as being frail. This is a specific diagnosis. Frailty has multiple other contributors. Sarcopenia can contribute to frailty. That is one thing. You mentioned some things about this particular patient. How many of these people actually come to you with a fracture already, or with having a fall, or having a tear or something? Or how many are incidentally detected, or how many are referred to you because they have a difficulty in walking? Can you just mention what kind of points are there? Means how many people come tell, doctor, I'm imbalanced, I'm not able to really walk well, therefore check me. Or how many actually come only, it is incidentally recognized because they came for a fracture or they came for a tear?
So there are two groups of patients that we would see here. The first group is the people who would, the elderly people who would come to for an outpatient consultation. So most common complaints that we see, of course, these back pains, knee arthritis, all these withstanding. One of the main complaints that they say is progressive difficulty in activity.
Progressive difficulty in
activity of daily living.
Yes. Yeah.
So it might just be fatigue, it might just be muscle pain. These are not clinically assessable factors. If we say, yes, you have knee pain, you have arthritis, this is something that we can clinically detect. But most of the time, yes, we say, it is maybe just old age, we'll just put you on some supplements. But as you clearly said in the first slide also, is that most of these people have developed a fear of becoming immobile. This is particularly very stressful, and that itself causes a lot of mental anguish for these patients. So these patients may have, they may, if they don't have any balance issues, if they don't have any neurologic issues, they may actually just be because of poor muscle strength and poor physiology. They tend to deteriorate over time. So these are the group of patients which are much easier to address. The second group of patients which I mentioned are ones who come to hospitals with a fall. In the elderly, when you take falls, there are two things which we see is, one is a major trauma. This can happen to anybody, injuries can happen. So these are not very, we don't consider them into the other group. This is called ground level falls. Okay? Ground level falls in the elderly are a cause of major problems because they land up with hip fractures, neck of femur, or intertrochanteric fractures. They can land up with spinal fractures. And what is unrecognized even now, in spite of having seen so many fractures, in spite of all of us orthopedic surgeons seeing these fractures day in and day out, is that the patient mortality after hip fractures is actually a major cause of concern for us. They will never ever come back to their pre-fall status of health. This is something that is extremely bothersome. They start to depend. They cannot get back their mobility in spite of what we do. See, invariably we operate these patients because our concern is that we have to get them mobile as quick as possible. We don't want them in bed. But in spite of all these efforts, the thing is, it doesn't happen. The second problem which we see, I don't know, it's an Indian thing, I think, is that we think that if a patient has not come back to me for follow-up, maybe the patient is doing well. But I think I've been saying it to a lot of our colleagues these days, is that if a patient with a hip fracture doesn't see you at follow-up, they are probably dead.
Okay.
It is that grave, right?
Yeah.
So these are the two kind of groups of patients. One is unrecognized. where we have to find out why they are here with vague complaints. The other group come with falls, come with some comorbidities. It might be fractures, it might be any other bony injuries, and then we in retrospect we diagnose these things as osteoporosis, sarcopenia, and related.
And it's also so happens that some of these people who have fallen would have actually sought medical help for difficulty, for fear of falling, at least a few years before, and most of the investigations would have shown normal, and just because we did not know an entity called sarcopenia exists, that no intervention was done. Is that right?
It is quite possible. See, I mean, in the last few years, when I've been seeing this sarcopenia come around, I'm not yet clear in my mind whether we can directly, have sarcopenia as a cause of imbalance.
Yeah.
But definitely, sarcopenia is a causative factor of falls. That is very clear.
Okay. So I think I can add some of the perspective that I come across in these patients with sarcopenia. Generally, the cases, I chose only one example patient, but then we have seen so many patients over the years. But in fact, the term sarcopenia was new to me also until recently, till one of my colleagues actually pointed out. But I was telling these people have no other problem other than loss of muscle strength or muscle bulk and strength. And that is the only thing that is. So for a long time, my interventions used to be to strengthen the glutes, so that because most of the time they have this kind of a waddling pattern of gait. Yes. And what happens is after a few days, they start getting the term dizzy, vertigo, and these kind of things. And it takes some amount of cleansing to actually ask them and make them tell what exactly is the thing that bothers you most. And they tell my main botheration is that I'm not able to walk. And that is my botheration. Then all that vertigo complaint, dizzy complaint, all that gets washed out. And the only thing is that, okay, I had an experience with a very senior surgeon who himself his only problem was loss of muscle strength and bulk. But the problem was he just came to me telling that I have vertigo. And what he had two big books of all investigations done from across the globe. He was quite senior. A lot of his students themselves were very big. So these kind of things do happen. So I think the more we recognize, I think, and one more good thing once we start recognizing is patients are reassured the moment they tell, okay, you're not cognitively declining. It is not Alzheimer's. It is not Parkinson's. It is not a normal pressure hydrocephalus. It is not a deteriorating cerebellum. It is loss of muscle tone, and you need to work for it. Then they'll be more willing to work towards it also. Okay, and overall population wise, this is a bigger thing. Okay, so that is the message. I'll come back to you, Dr. Venkat, about what more we can do for these patients. Before that, I want to go to Dr. Aditi. Dr. Aditi, if an youngster who is in the 20s or 30s comes to you, okay, because sarcopenia is now being recognized as something that begins in the 30s. Okay, after 30 years of age, it starts beginning, and then only this thing. So if somebody comes to you at 30 and then tells, ma'am, what am I supposed to do so that I don't become frail? Okay, what is your advice, and what exactly is the regimen that you will be telling?
The first thing I would like to know is the lifestyle. How is the lifestyle? Because sedentary lifestyle is contributing a lot to the middle age population for sarcopenia. So the lifestyle history and changes in the lifestyle would be my first suggestion, to have more physical activity added to their lifestyle, and at least a 40 minutes of physical activity, which includes cardio and also a resistant training or a weight training exercise would be my first and foremost suggestion for all age group to avoid such conditions, or at least reduce the chances of sarcopenia in the future.
So one is resistance.
Yes.
Okay.
So
and if yeah, yes, ma'am. Weight training, and then at what age you think people should start giving importance to the stretches and flexibility?
Stretches, flexibility should be a part of their life in all stages of life, which is very much important, be it their adolescent, adulthood, or their early geriatric age group also. Flexibility is something which they need to do every day, but along with that, the resistance training or a weight training just to build up the muscle, to have a good strength. It's not bulking of the muscle, but to have good amount of protein in the muscle so that it's strong enough so that it will help you in the future in their early geriatric or geriatric phase of life. It will help. So that would be my second suggestion, to have a good protein intake and also maintain the protein or the muscle strength.
Now, so that directly leads me to the next question, and that is, how much important is it that they should actually recruit into a gym, or how many of these exercises are possible without equipment at home?
So for just maintaining the muscle strength, there is no requirement of gym. Very basic equipments or tools which are available are in and around your home. So that can be used. Like one simple thing is weight cuffs, which we get like 2 kg weight cuff, which they can purchase online also, and that and a resistance band which is used. So that can be used at home only. And along with that, there are very simple exercises like squats, push-ups, which doesn't need any equipment. Those are like body weight exercises. So these can be performed at home itself without hitting the gym.
Okay, so it is not not a must that they have to join in a gym or something. There are exercises that they can do at home.
Right.
Dr. Venkat,
Yes, sir.
how much is the role of the hypogonadism as a cause of sarcopenia, and are there interventions that are being thought of hormone replacement therapy to handle this sarcopenia?
So one thing is, of course, one of the main things is growth hormone and insulin-like growth hormone. These are very important for maintaining muscle mass. But also now in women, when we see it, generally this decline starts to happen post-menopausal, when after post-menopause, and even in men. So because there is a significant higher level of testosterone, the muscle mass is maintained much better. So that is the fundamental difference that we cannot really see anything about. But there is definitely a hormonal role in muscle mass, and people who have low testosterone levels are more prone to develop sarcopenia at older age.
So is there a general recommendation which we can make to the population, like after this age you have to get your hormones level tested, something like that, as a screening test?
No, I don't think there is a role for routine testing of any sex hormones at this moment. The only thing is what is routinely checked definitely is we have to look at their metabolic history, because that seems to have more pressing, not only a need, but it has a more direct influence over sarcopenia as a whole. If they are obese, if they have a metabolic syndrome, if they have thyroid issues, if these are things that we come across routinely, and these are common things first. That is the simple dictum I would suggest. And above 50 years, I would definitely recommend patients to have a DEXA scan. So women in particular, men we can think about it post 65, but women post menopausal, definitely DEXA scan is important. We don't give it much importance. Even now, we don't really bother until the patient comes with an osteoporotic fracture, or if you really suspect that there is osteoporosis, we don't really routinely recommend DEXAs, but it is essential. And most DEXA machines, they are capable of giving a lot of information, especially with regard to muscle mass. But most of the places, they don't have the software, although it's just a matter of adding the software. So I think there is a lot that we can do and lot we can assess and improve even with our present infrastructure to be able to detect these things.
So what you're saying is that dual energy X-ray absorptiometry the equipment is available, but the softwares to actually measure the muscle mass is not there. They are more concentrated on what is happening in the bone. So the look at the muscle has not yet begun. So there is a lot of change that needs to happen in the out there, even in the labs. Is that right, sir?
Yeah, that is true. The other thing is when we get MRIs for any other reason, example, if I were to get an MRI of the shoulder or for a rotator cuff injury, adhesive capsulitis, anything of that sort, or if we get an MRI of the spine for any degenerative disc disease or disc prolapse, we definitely start seeing evidence of fatty infiltration. What you mentioned about, muscle quality is not just the muscle bulk, it's the muscle quality. So if the patients have rotator cuff tears and if the MRI is showing fatty infiltration in the muscle, then the outcomes of repair of those tendons is much lesser.
Okay.
And when the muscle is normal. So definitely this fatty infiltration plays a very significant role. And I think it needs to be picked up and studied a lot more.
Okay. Okay. So I'll go to Dr. Aditi once. Okay. Dr. Aditi, these, in your experience, the people who have lost muscle, how much is it reversible? How much do they gain back? Not in the athletic people, but in the elderly, like post 50, or post 50 is not actually elderly, but in that age group. If somebody comes with already lost muscle for whatever reason, maybe because of an intercurrent reason, illness, or because of this thing, okay, to what extent is it reversible? You really aim to reverse that loss of muscle, or you just aim to maintain the amount that is already there?
So for a geriatric population, usually they have a lot of comorbidities. So it becomes very challenging to get back the muscle loss, but the volume or the everything. So if the loss is not more than 30%, there are chances of getting back the muscle mass. But otherwise, our main focus is always to prevent more muscle loss, and also to make sure that they
maintain the amount. Yeah.
Hello.
We are able to hear you. We are
Yes.
able to hear you.
Yeah. So to make sure that they maintain the strength and the mass, and also prevent further loss. So prevention and also maintenance is what we aim at.
So if to achieve this, how many minutes in a day should somebody give themselves to just maintain their muscle mass and body, so that they go on and on? How much of time should somebody to give? See, there are some people who tell, okay, we need to sleep for 7 hours, 8 hours, then we need to meditate for half an hour. Then how much time should be given for exercise?
So the WHO standard itself says that a 40 minutes to 1 hour of any physical activity is more than enough to maintain the quality of life. So the main aim for a normal population or an adult population is to maintain whatever is the physical activity or the health. So in that 40 minutes or 50 minutes of their dedication, they can divide it. And for the resistance training, as I said, probably a 15 to 20 minutes of strength training or a resistance training will definitely maintain and also improve the strength.
Okay, so 15 to 20 minutes of the strength and resistance training,
Definitely.
remaining 20 minutes of some activity.
Yes, strength activities. So
Strength
if it's
activity.
yeah, so if it's a 40 minute of a workout or the dedication they are giving, so probably a 15 to 20 minutes of a walk or a jog or a normal walk, just a normal walk for the cardio part, and to maintain their cardio health, and 20 minutes of exercises, few exercises related to their shoulder or the upper body, 2 to 3 exercises to maintain their core strength, and few exercises to maintain their thigh muscles, which is very much important for their walking, for their mobility. So 10 to 15 repetition of an exercise would be good enough to maintain the strength.
Okay, so to summarize, one thing is that they need to spend some time, WHO 40 minutes, then a few minutes of that 40 minutes for cardio, remaining is for strength and resistance. In that, Dr. Aditi brought out a very beautiful point, and that is that upper body, core, and lower body. Okay, we should see the three things as separate. So upper body, when you talk about upper body, it is about shoulders, it is about the arms and all those things. It is about flexibility. Some people think that not being able to reach the back of their shoulder from the back side is being a big man. You see in the villages and all, somebody is too big, he does not rub his own back. He has an assistant to rub his back, okay, for taking bath and all these things. So that is considered as a higher status, but it is not actually. It is actually loss of agility. So upper body, both flexibility and strength, then the core flexibility and core strength, and then the lower body Dr. Aditya was talking about the thigh and all these things. So the three different things to be concentrated so that the muscle mass is maintained and the agility is maintained.
To add on to
Yes,
this, along with the
yeah.
muscle loss, there is also loss of muscle control. So a bit of balance exercises, which is very much important, because to add on to the case which you had discussed, the diagnosis, the patient came with the vertigo diagnosis. So at some
Patient came
point,
with imbalance.
yeah. So along with the sarcopenia also, the chances of loss of muscle control is also there. So a little bit of balance exercise would definitely help the patient.
Wonderful. Yes. Dr. Venkat, what kind of protein supplements you give, or what kind of nutritional supplements you give for these patients to whom you, once you recognize that their muscle mass is reduced?
So in the younger patients, usually we need to improve their overall diet, and we definitely. So what I have been suggesting now is that a lot of people come with, they want to reduce weight. So what I've been trying to say is, yes, of course, they try a lot of unrealistic diets. They try some, for a few days, they try some keto diet, and then they try all fruit diet. They try all sorts of things, which is probably, if it's not done properly under supervision, it probably causes a lot more harm. So what I have suggested to a lot of patients, and probably kind of it is a low hanging fruit, it's easily accessible, is that you take your normal diet, you take your routine diet, whatever you cook at home, you eat the same, does not matter. Don't worry, oh, I'm eating more rice, doesn't matter. What you do is cut down your carbs after 6 p.m. right? And that is something that is doable. As long as you don't change your diet in the morning time, it's pretty easy to cut down carbs in the evenings, right? And start having slightly higher proteins in the morning time along with your normal diet. So at least these are doable changes which people are not intimidated about.
Yeah.
So the moment you just, if not just about decreasing the carbs, you're also changing the ratio of your protein, carbohydrate, and fat intake. This itself helps them to get their metabolism slightly better. That is one thing. In the elderly, especially after injuries and post-operative rehabilitation, I definitely put them on protein supplements. So if they are younger, below 50s, we just suggest any of the protein supplements, whey protein, soy protein, peanut protein, anything, hydrolysate. So it helps their recovery. And but elderly patients, they don't tolerate protein so easily. So what I have switched to over to, especially, example like post replacement surgeries, post fractures in the elderly, there are essential amino acids which are available. It comes in a packet of about 4 to 8 grams. So I suggest they have this every day, at least, because of course you're directly giving amino acids. So what I've seen is they tend to tolerate it better, in terms of digestive complaints. And immediately post exercise, there is some evidence to say that, immediately after your exercise, when you are given some supplements, especially these amino acids, they may regulate muscle function and improve muscle recovery. So that is something I've been doing over the last couple of years, I guess. Now, so this amino acid powders we give, and if they are into sports, we do suggest, but I definitely direct them to a sports nutritionist. But one thing is, add on a bit of BCA, branch chain amino acids, immediately post workout. That also helps a bit in muscle recovery. But it's not I would not say it's a end to everything. It is not a complete solution. But the most important thing is, it's not just about saying, I will add proteins, because there have been enough studies on it. The effect sizes are not big enough to say that protein is going to make a big difference in your outcomes. But definitely there is some evidence that it does help to improve muscle recovery post exercise. So definitely whatever Dr. Aditi has told, regarding what all kind of exercise they do. So as soon as they do their exercise, if they have a bit of a higher protein intake, and if they are elderly, they don't tolerate full proteins, hydrolyzed proteins, they can take amino acids. Definitely, it helps.
So that was very nice points. So just to summarize, one thing is to reduce carbs. Okay, one thing is simply don't go into fats of different kinds of fats to reduce weight without supervision is what Dr. Venkat emphasized. The next very important point he mentioned is about protein supplementation. Below 50 and above 50, below 50 they tolerate protein supplementation, the way the proteins are available in a lot of the supplements. But when it comes to the elderly, they may not tolerate the hydrolyzed the protein hydrolysates. So in that case, it is better to give individual amino acids. In the sense they come as sachets. So the amino acids are a better choice and they are better tolerated by the elderly. So thank you for that very lovely information, sir. There were two questions here in the chat box. So one was by Dr. Ekamba Reddy. Okay, that patients may have low creatinine. Could that be an indirect indicator of people with sarcopenia? In fact, sir, that is already recognized as one of the investigational tools in the European consensus group. They are doing something called creatine dilution study to assess the amount of muscle bulk. Then Dr. Pratishtha is asking, during the beginning of arthritis at the age of 40s, okay, can we continue high energy games like lawn tennis? Is it safe for the joints? Dr. Aditi, you want to say things about that?
Right. Until unless it's not causing any issue, there is no pain or anything, she can, but not at a high intensity. Probably she can make it as a moderate intensity. So any sport can be, yeah.
So moderate intensity, but they can continue to play the games. And
Yeah,
to what extent having good muscle bulk will actually prevent osteoarthritis from developing in the first place? I want both of your opinion, Dr. Aditi first and then Dr. Venkat.
Okay, so muscle bulk as such, it
not just bulk, muscle strength, good muscle strength. Is it going to be protective against osteoarthritis?
Right. So what muscles actually do is it takes the maximum load, whatever the body is putting into. So the good strength will reduce the load on the joint directly. So when there is less load on the joint comparatively, so the degeneration process slows. So degeneration is something which we can't stop. It's an age-related issue. So we can only delay the process and take care of the joint. So muscles, the stronger the muscles, lesser load on the joint. So postponing the degeneration process.
Okay. Dr. Venkat, do you recommend building muscles also to make sure that your surgical load is reduced?
Absolutely. There is no doubt about it, because see, the first intervention, the most basic intervention, if a patient, example, comes with knee osteoarthritis, the basic intervention that we want to do is start them on exercises. So if most often what happens, if their quadriceps are already atrophying by the time they start getting a lot of pain, that's basically a lot of muscle inhibition. Eventually it goes into atrophy. Eventually they develop what you mentioned in the first, they start having a lot of waddling gait. That is basically, that is hip abductor inactivity. So the first thing we would definitely recommend to all patients is to do a lot of exercises. We start with isometric exercises, and once their pain comes down, we start doing more resisted exercises, and we can develop the strength on that. So definitely, as Dr. Aditi mentioned, it reduces the joint reaction forces. So, and it offloads the joint significantly. So the amount of damage that happens to the cartilage is definitely much lesser in a strong muscle.
Okay. So thank you, sir. And Dr. Nigil is asking a question. Would you recommend protein supplements in young healthy individuals? Does this prevent sarcopenia in older ages? One of the things that is mentioned in the European consensus committee paper is try to build as much muscle as possible in the young, so that they have more muscle bank, so that when they start losing, they still don't. But there, I don't see whether this has to be achieved by by protein supplements or just by exercises and good enough diet, I'm really not sure. But I will take the opinion of Dr. Venkat here. Dr. Venkat, for an youngster, would you suggest protein supplements or only good nutritional diet?
It's a good nutritional diet is important because see, there are two things here. Now, example, we look at peak bone mass, and
Yeah.
this peak bone mass is highest. It is the highest when it is about 30 to 35 years, and after that it starts to decline. Now, peak bone mass and peak muscle strength almost have the same graph. Now, if you are not exercising, the muscles are weak. Therefore, your peak muscle strength is less. And when there is a peak muscle strength is less, the amount of calcium or the amount of mineralization in the bone is automatically less. So your peak bone mass also is less. So therefore, just taking a supplement is not going to do anything because your body doesn't need it. So even if I take excess protein, eventually it is just going to store in the body. You're just going to put on weight. You're not necessarily putting on muscle. So until you develop the strength, now by exercising, by maintaining a good muscle tone, by maintaining good muscle activity, you're increasing the strength, and thereby the muscle is putting a strain on the bone and you're increasing the bone mass also. If you're not exercising, there is no point in adding a supplement. It's not going to do anything.
Okay. So basically it is like exercise first, create the demand and then provide for the demand.
Yes.
Okay, rather than overflooding. That's a nice point. Thank you, sir. Thank you. So I think so. We started off with one patient who's been coming, one category of patients who keep coming to the vestibular clinic with balance disorders, in whom you end up finding nothing else is wrong. Their MRIs are normal, their CT scans are normal. Most of their vestibular evaluation may show a few vague abnormalities which are not sufficient explanations for their problems, and they have an intense fear of falling, and also they express a fear that they one day may become immobile. So in that context of the patient in whom everything else is not there, we saw the gait of one particular patient who was more waddling, and then went into the muscle bulk, and that actually not just exactly the muscle strength, because there are some times where muscle bulk can be maintained because of fatty infiltration, but the strength is not there. And then we went through the European consensus guidelines. Then we saw how to pick them up, including grip strength, 5 times getting up in a chair. And there are multiple other parameters for screening and also for evaluation, and some of the methods of treating these patients if they are recognized early, which includes a good nutritional diet and exercises, which will be able to help a lot of patients. As of now, today's discussion, I asked Dr. Venkat, any role for any hormone replacement therapy? As of now, there doesn't seem to be a role for hormone replacement therapy itself to maintain the muscle bulk, is the opinion of the panel today. So we go with the nutrition and exercises for these patients, but most important is recognition that this condition exists. And this is not to be taken as frailty of the elderly, frailty with age, whatever. This is actually because of muscle loss, and can be intervened and can be helped. So with that, I want to take the final of views of Aditi first, and then Venkatdeep. Dr. Aditi, closing points.
So yeah, sarcopenia more like a disorder. It's more like a condition, just like how diabetes and BP
A diagnosis,
is so common.
yeah.
So and diagnosis is first thing. So all the clinicians should always keep this point in mind. And second thing, once they're diagnosed with sarcopenia, so the next thing is always good diet and good exercise. They have to, at some point, they have to spend 1 hour in a day to exercise to take care of the body. Ultimately, body is going to take care of them in the future. So yeah, exercise is the main, and then comes the nutrition.
So I have one more question. When you take the metro station, and there most people are taking the escalator, hardly one person will be walking up the stairs. What do you have to tell to those people who are taking the escalator?
They should probably stop that. Now they take the escalator, later they'll have to end up on wheelchairs.
That is an indication of us as a city, because that is a population sample. of us as a city,
Right.
where we are going and how healthy we are living or whatever, and how much. If somebody 1, 2, 3 flights of stairs, if they think they become breathless or they cannot walk, so eventually all these patients are going to tomorrow go to Venkat Deep for surgeries. Is that right?
Definitely.
Yes, sir. Final thoughts, Dr. Venkat.
Yeah. So the couple of things when you mentioned about the hormone replacement, I just remembered. Of late, there is a lot of interest, especially abroad, that there is a lot of research on anti-aging. So one thing is people are actually kind of, to be honest, the best word would be abusing metformin. So metformin, though it is used for diabetics, the good part about metformin is it increases the insulin sensitivity, but it does not cause hypoglycemia. So apparently there is some, I mean, I haven't really gone through much literature on it, but there is some role for maintaining, general health and muscle strength using metformin. I don't advocate it, and I think the data at this point is very primitive and probably more disastrous only if you were to ask. And the other thing is there is a lot of research going on for monoclonal antibodies. Again, now we use denosumab for improving bone density. The same way there are some monoclonal bodies in the works to help to improve the muscle mass. And the other part which they're doing a lot of research is androgen receptor modulators. So this also kind of comes in where you don't have androgenic effects, but you still retain its effects in terms of improving muscle mass and things like that. So these are kind of future directions I would think of. As far as our work goes as clinicians, I think we have to start understanding that its implications, sarcopenia implications, are far more than just saying, it is just muscle weakness. So it is very under recognized, and we, of course, even in literature, there is no consensus on many things because the population size and the factors which they take into consideration are very varied. But there are a lot of directions for us to take and start understanding as a whole that we need to address it. And definitely it has a lot of implications for us in practice. So definitely have to watch out. And basic exercise, I think Dr. Aditi has given a very good overview on it, that you have to focus on multiple, upper body, core and lower body exercises, and even small improvements in your muscle strength, aerobic capacity is going to take you a long way in maintaining a healthy muscle mass and muscle function more rather.
Thank you, Dr. Venkat, for those final closing comments. Okay, and also telling about the possible directions, the future directions that drug therapy could lead us to, and also warning about the metformin abuse. Metformin abuse comes from some of these. There are some YouTubers who tell about taking metformin to reverse age by 10 years, 20 years, and all those things. So I think that is what is leading to the abuse. There is, I think, one last question that is there from the audience from Dr. Saurabh. Dr. Saurabh is asking any closed differential diagnosis or mimic which we need to consider in case of sarcopenia. I think the close differential diagnosis we need to consider is the secondary sarcopenia causes. Like if somebody is suddenly, like even in sarcopenia, there are two things that are recognized by the European Consensus Committee. There is an acute sarcopenia and a chronic sarcopenia. If somebody is suddenly starting to lose weight, possibly you have to start considering there may be underlying inflammatory condition or a malignant condition which is making them lose. It may not just be age related or a sedentary lifestyle related. Okay, if it is just sedentary lifestyle and age related, that's another thing. But then if somebody who's active, who's doing exercises in spite of his active life, still losing muscle, then I think we need to consider. So these are the things. The secondary causes is what I think should be kept in mind as mimics. Okay. So I think with that, with that, we have come to the we've been discussing this for about an hour. So thank you both Dr. Venkatdeep and Dr. Aditi for joining us today and adding your wonderful points. I'm sure a lot of us will start recognizing sarcopenia as one of the differential diagnoses when it comes to a person who comes with the main complaint of fear of falling or a difficulty in walking, also in those patients too who express an fear that they eventually may become immobile, those kind of things. Also, it should prompt us that from now onwards, people from their 30s onwards start working towards maintaining muscle strength and include exercise as a good a part of their daily regimen, so that as we grow, all of us, to calendar age is something that we cannot stop. Okay, calendar age is something that keeps going, but aging by calendar need not mean we start becoming more frail, more weak, bedridden, and all these things. So that is not an inevitable consequence of aging. So we can age in a healthy manner and live more healthy lives. So thank you both. Thank you, Dr. Aditya. Thank you, Dr. Venkatdeep, for joining us at a very short notice. I usually give short notices because I want you to give your frank opinion from your practice only, and that is what has come out today, and that is the most useful opinion also. So thank you both for joining, and thank you for all the my friends, all the people who have joined us, who have been joining us over so many months. This is the 10th grand round. So thank you so much, and till we meet the last Friday of next month. So good wishes to all of you. So thank you all. Thank you. I think there is something in the chat box. I'll just see if there is something mentioned. This is okay. Thanks. Thank you. Thank you, Dr. Danya.